white paper on correlating the intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Tubercular granulomas are the most well-recognized phenotype of intraocular tuberculosis, and these are hypoxic granulomas associated with increased levels of VEGF. VEGF is a known biomarker for active TB disease both in pulmonary and at extrapulmonary sites. The purpose of this study was to evaluate the intraocular VEGF levels in TB choroidal granulomas and correlate them with the clinical regression. The secondary objective being to evaluate the visual improvement in these cases. Ethical clearance and an informed consent was taken, and 10 consecutive patients with intraocular TB granulomas were enrolled. The aqueous sample was subjected to a sandwich ELISA test, and VEGF-A levels were measured using human VEGF antibody pair kit test. Intravitreal injections of bevacizumab and moxifloxacin were given every week till the granuloma regressed, and systemic therapy in the form of 4-drug ATT and corticosteroids were continued. A correlation was then done between the decreasing VEGF levels and the clinical regression of these granulomas. 10 eyes of 10 patients were included, and the mean age of presentation was 25. 8 patients had choroidal granuloma, and 2 patients had optic nerve granulomas. This just shows the decreasing levels of VEGF on giving subsequent intravitreal injections. And this table shows the clinical regression of the TB granulomas in these 10 patients who were enrolled in the study. The results which were got in the study, the mean baseline VEGF-A level was found as high as 1000 to 1500 picograms per ml, while the mean VEGF-A level at the time of last injection was as low as 27 to 50 picograms per ml. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting intravitreal injections, and the average number of injections required by these patients were around 3. At baseline, 9 patients had a best corrected visual acuity of less than 636, and this had improved to 4 patients having a vision of 6.6 at the last follow-up, 2 patients with a vision of 6.18, and 4 patients with a vision less than 6 by 24. This is one of the representative cases, a 24-year-old female with diminution of vision in the left eye for last 5 days, already on ATT for pulmonary tuberculosis. You see a large choroidal granuloma in the supranasal quadrant, along with involvement of the optic nerve head and cystoid macular edema at the macula. The VEGF level at the baseline was 927, which had decreased to 422 after 1 injection. You see a beautiful regression of the entire choroidal granuloma. But the patient developed a paradoxical reaction, and this was treated with IVMP and stepping up of the oral steroids. There was a complete regression of the entire granuloma after 2 injections, and the patient had recovered a vision of 6.6 N6. This is another patient with a massive granuloma involving the macular area with a vision as low as 3 by 60, which had improved after 3 injections to 6.18, and you see that the granuloma has totally regressed within a time frame of about 4 weeks. So TB granulomas are hypoxic granulomas with increased VEGF-A levels, and they are said to have VEGF levels as high as 4 to 5 times higher than what is found in AMD CNVM patients. The half-life of intravitreal injection being 2 to 7 days. In non-vitrectomized eyes, it is tending to reduce in these patients because of the breakage of the blood-retinal barrier, secondary to inflammation. This is a typical TB granuloma with caseation necrosis in the center. You have surrounding macrophages, which are having the TB bacilli within them and the abnormal vascularization. These granulomas, the VEGF levels are high, leading to abnormal vasculature around the granulomas, leading to unequal distribution of the ATT drugs, thereby reducing it to a monotherapy and thereby increasing the risk of multi-drug resistant TB. These hypoxic granulomas and the hypoxia associated makes the MTB bacilli dormant, and the INH, which is there in the ATT, is the only bactericidal drug, but it does not act on dormant bacilli. Thus, the need for innovative host-directed therapies. When we give an anti-VEGF, there is a decrease of hypoxia. It avoids the bacilli from becoming dormant and increases the effectiveness of INH. It also normalizes the vasculature of the granuloma, thereby increasing the small molecule delivery of ATT and reducing the risk of multi-drug resistant TB. While moxifloxacin being given, it accumulates in the activated macrophages, which harbors the MTB bacilli, with a higher intracellular to extracellular concentration in comparison to other ATT drugs, and thereby helps in elimination of the MTB bacilli from the macrophages. The VEGF-A levels were measured for the first time in this study, which probably can be used as a biomarker in future. An effort is to normalize the vasculature of these TB granuloma as quickly as possible so that the ATD drugs effectively reach the granuloma and regress them. It was a proof of concept study and hence the small numbers, and it was also a non-randomized study. So these were the shortfalls of this particular study. I conclude by saying that very high levels of VEGF are found in patients with tubercular granulomas, and a monthly injection of anti-VEGF may not be enough to aggressively treat these vision-threatening TB granulomas. A weekly intravitreal injection of anti-VEGF with moxifloxacin given as an adjunct to the ongoing ATT and steroids may help in faster regression of these granulomas. I just acknowledge the contribution of NIN and Professor Ramod Gupta for all our knowledge on ocular tuberculosis. Thank you so much.
Thank you. Manisha, just one question. How you collected this sample for a VEGF level?
So, sir, when we were giving the intravitreal injection to these patients, we just did an AC tap, which we normally also do sometimes because of the high IOP, because we were combining two drugs. So at the end of the procedure, we just collected a small AC tap sample. Thank you.
Yeah, next speaker is Dr. Ashish Ahuja to evaluate patient compliance for prone positioning after retinal surgery using an innovative device. Dr. Ashish is here.
Good morning, everyone. So I'm Dr. Ashish Ahuja. I'm a Vitreo retina consultant practicing in Mumbai. I'll be presenting a paper to evaluate the patient compliance for maintaining prone position after vitrectomy surgery using an innovative device, which my team has developed. So I'm an equity stakeholder in the healthcare startup VisionCure Private Limited that is manufacturing this device. So the problem we are trying to solve is that prone position is needed for patients after retina surgeries for the tamponade agent to support the retina. In the real world scenario, it's very difficult for patients to maintain face down position, which is due to various reasons like a back problem, giving rise to uncomfortable posture, leading to chest pain, and then there is no real way to track the duration for which patients spend time face down. And the failure of patients to maintain face down position can affect the surgical outcome in certain cases. So we did a study to investigate the use of this innovative device that has a sensor embedded in the headrest of the furniture with data logging function to measure the compliance of patients to maintain face down position after retina surgery. So PVRS is a short form for post vitrectomy recovery system. It's an innovative device to help patients maintain prone position, track the duration for which the face down positioning is maintained, and it helps to improve patient compliance and also the surgical success. So device mainly consists of a tripod shaped furniture which has a horseshoe shaped cushion on the top, and we had embedded a sensor in the center of the horseshoe shaped cushion. It's a pressure sensor which relays the data via SIM card. So when the patient places their head on the cushion, it triggers the sensor and the data is relayed to our server online. So this is a live relay of how the dashboard on the website looks. So we have a dedicated server where the data is sent in small pockets. So every time patient puts his forehead on the cushion, if the patient lifts his head up after a minute or 2 minutes, so that each activity is tracked and the data is relayed, and we get a cumulative graph at the end of the day. So the doctors and patients can track over the 2-week period as to how many hours the patient has maintained a face down position. So in this study, all surgeries were performed by me. Patients were asked to maintain face down position for a duration which they felt was comfortable. 11 patients were included in the study after informed consent. Surgeries done included macular hole retinal detachment. One patient had an open globe injury with RD. So the face down positioning duration varied from 4 days to 12 days. So what we observed was the adherence to maintain face down position was better in a macular hole surgery compared to retinal detachment. Maybe also because the duration for which FDP was advised was for lesser number of days. Adherence was found to be slightly higher amongst females compared to males, which varied for about 5.5 hours per day compared to 4.5 hours. Out of 11 patients, all patients with macular hole achieved anatomical success and successful hole closure. Out of patients with RD, one patient had a redetachment who was operated. So we were tracking the duration of face down positioning on daily basis and plotted in this table for convenience. So the compliance was better in the initial 1 or 2 days and started decreasing over a period of time. What we had noted was if we inform patients that we are tracking their face down positioning, the compliance tends to be slightly better because they know they are being monitored. So vitrectomy surgeries in real world scenario, we would want to improve the surgical success even if it's by 5 to 10%, if the patient is maintaining a good position, especially in cases with detachments with inferior breaks. So to conclude, we observed a good acceptance of our device to measure patient compliance after the surgery, and the significance of maintaining a face down position is underway. We are doing bigger validation studies and working on different furniture designs. So this current design was basically used in sitting position, and the horseshoe cushion is detachable, so patients can remove it and use the same in lying down position as long as the cushion is connected with a power bank which will supply the electronic circuit. The data can be relayed. Thank you for your time.
Yeah, nice innovative thought. Did you compare the quality of prone position compared to a normal sitting on a table and putting it? Tracking is good, but how effective it is for your shoulder and neck pain?
Again, in that position, neck pain and back pain are there, but so we have started using a questionnaire now as to the pain and the comfort on a scale of 1 to 10. So patients are in the bigger validation study which is underway currently. Patients do find it better. Means the furniture need is definitely there.
Yeah, that data will be interesting to know also. Thank you.
How are you sure the patient doesn't accidentally touch the sensor and you get wrong data?
Yes, sir. So the sensor is calibrated for at least, we need a pressure of about 1.5 kg. So just by placing a finger or, something touches, it will not trigger.
Sensor is in the center or in the periphery of the, that you
In the center of the horseshoe shaped cushion.
If his face doesn't touch that sensor,
Then it
he has
will not
flat
trigger.
nose, if he has a flat nose or something.
So the forehead, sir, on the horseshoe shaped cushion, where the forehead is placed, that area has the sensor in the
Okay.
center.
So it is in the periphery. Okay.
Both of you can discuss this.
Yes.
Thank you.
Next.
Next.
Go ahead.
Next speaker is Dr. Shilpi, Management of Stage 4 Neovascular Glaucoma in
Good noon, everyone. Thank you, AS, for this opportunity. This is a study of stage 4 NVG in PDR to assess the efficacy and superiority or the equivalence of single-step versus two-step procedures in cases of stage 4 NVG in PDR. In stage 4 NVG, the fibrovascular proliferation causes closure of the anterior chamber angle. NVG in PDR contributes to approximately 21% of the cases. It is usually bilateral and more commonly seen in type 1 diabetics. Patients present with raised intraocular pressure, corneal edema, NVAs, and the closed angles. Besides treating the systemic disease, the main aim is to reduce the inflammation and the IOP, which can be done by treating the underlying cause, that is the ischemia, which holds true even for the principal in management cases of the stage 4 NVG. But the challenge is that in spite of the maximum treatment, in maximum cases, the IOP does not come down, and because of the more inflammation and more IOP and corneal edema, you cannot treat the major cause to reduce the VEGF surge, that is the lasers. And in this time, the IOP remains high and it causes the damage to the optic nerve. This study shows the overall success rate of 61% at 6 months. This showed the average success rate of 67% at 1 year and 61.8% at 3 years. While this is a case of the combined procedure showing the complete success rate of 52.9%. This was the subsequent two-step procedure. While in this combined procedure surgery, they showed the success rate of approximately of 100% at 6 months. This article of the PLOS One showed that if the trap fails, there are more chances of needing a vitrectomy in such eyes. So the aim of our study was to compare the success between two-step approach and the single-step approach in cases of stage 4 NVG secondary to the PDR. It was a prospective interventional study. The patients were divided into 2 groups and the exclusion criteria are illustrated here. In group 1, after controlling the IOP, the patients underwent pan-retinal photocoagulation followed 2 to 3 weeks later by trabeculectomy and MMC preceded 3 days before with the intravitreal bevacizumab. While in group 2, patient was directly taken for the combined procedure preceded by the intravitreal bevacizumab. This surgery shows the phonics after creating the phonic conjunctival flap. The MMC soaked sponge were kept for the 2 minutes. Partial thickness 4 mm by 4 mm scleral flap was created. Kelly sponge is used to create the inner window. Scleral flaps were sutured. After this, the thorough 23 gauge vitrectomy was done and the lasers were done up to the ora serrata. Similar steps were done in the group 1 except for the pars plana vitrectomy. Now coming to the results and discussion. These were the statistical methods used in our study. This chart shows the descriptive statistics for demographic and clinical parameters of the patients in both the groups. When we compare the ocular parameters, if we see a intra-group, there is statistical reduction in the IOP over the 6 months period of time in both the groups. But if we look between the groups, the IOP reduction at 6 months was 20.5 in group 1, while it was 26 in group 2. The number of AGM needed at the 6 months was 1.5 in group 1, while it was 2.13 in the group 2. So the reduction was 1.38 in group 1 and 0.88 in group 2. If we see the visual acuity, the change in visual acuity was 1.13 in group 1, while 4.38 in group 2. The 4-line improvement was seen in 5 cases in group 2 compared to the 1 in group 1. While we could save the disc in 7 patients in group 2 and only in 4 cases in group 1. This all concludes that because of the intervening period in the group 1, the IOP remained high, which causes the further damage to the disc. These were the transient complications which were seen and were comparable between the 2 groups. When we compare the type of the success achieved, there was no difference in complete and qualified success between the 2 groups. The KM plot showed the early and sustained reduction in the IOP in the combined group. To conclude the results, if we see, the gain in vision in combined group was 4.38 compared to the trabeculectomy group, while the mean reduction in combined group was, the mean IOP was 17 mm, while in the trabeculectomy was 22. Need of AGM post-operatively in combined group was 0.88 compared to 1.38 in the trab group, and the cumulative success rate was 100% in the combined group, while we have 2 cases of trab failure in the 2-step approach group. No significant differences were seen intraoperatively in any of the groups. These are few pre-surgical slit lamp and fundus photos and the post-surgical pictures of the patients. To conclude, despite treating the strict systemic control and early treatment, even we can salvage the vision with the timely and aggressive management. In our study, the single-step combined approach was found to be more effective in controlling the IOP with better visual outcomes. The limitations is the small sample size and 6-month duration of the follow-up. Thank you.
Statistically, there is no significance between the two groups. It is only just your feeling and the number is very small.
No, so statistical difference, we have...
There are p-value is never below 0.05.
Yes, sir, because of the small sample size. But if we see the number of the reduction in the AGM post-operatively or the amount of the reduction in the IOP, it is more.
But that is by chance. That could be because of chance. Unless until statistics proves it, we cannot say. Anyway, thank you. We'll go to the next.
Yeah, ask her to come.
Yeah,
Please.
Just here?
your name?
No, wait.
Debalina Dev, no?
Debalina, she has to go another all.
Okay, that's okay. Okay, next. Okay, sure, please.
Good morning, respected judges and everyone. My name is Dr. Debalina. My topic is on profiling of risk factors between type 1 and type 2 ROP and comparing their involution. Coming to the introduction, as we know, ROP is a vascular proliferative disorder seen specifically in the preterm babies who have partially vascularized retinas. Coming to India and the other developing countries, ROP is coming to the third pandemic due to the improved NICU care and the improved survival of the small babies. Because of this, on the offsite, there have been an array of morbidities pertaining to the eye. ROP is one such, which if it is untimely managed would lead to permanent blindness. The aim of a study was to study the various risk factors associated with the progression of ROP and also to analyze the age at which it is detected, progresses and regresses. This will help us to monitor which is the crucial period to monitor these babies and to follow them up more regularly. Ours was a prospective longitudinal study over 3 years done in a tertiary care center in Chennai. We included 202 babies with any stage of ROP and included babies with gestational age less than 34 weeks and birth weight less than 2,500 grams, and they were staged based on the ICROP classification. We excluded any babies who died or lost to follow-up beyond 40 weeks of post-conceptional age. So we started screening all these babies from day 21 of life or 31 weeks of PCA, whichever was earlier, and the follow-up was based on the vascular status on the current visit. Based on the ETROP classification, these babies were classified as type 1, type 2 and mild ROP. We assessed 22 risk factors, which I'll be presenting in the next slides. And we did the descriptive study comparing both the univariate and multivariate regression analysis, and the statistical p-value was kept as a cutoff of 0.05. Coming to the results, out of the 867 babies, 23.3% were diagnosed with ROP, but 60 were excluded because we lost them to follow-up. So the corrected incidence was around 16.4%. Most of the babies were male babies, and all babies with type 1 underwent peripheral laser ablation, out of which only 2 needed additional intravitreal bevacizumab injections. Based on the ETROP classification, most of our babies, they had type 2 ROP. Out of the type 1 ROP, out of 53 babies, 3 also had aggressive posterior ROP. This is a picture showing a ridge based, which is on the left, that shows the stage 2 zone 2 ROP with plus disease, and on the right, it shows a regressed ROP after giving laser. The risk factors we first compared between babies with ROP and without ROP and found a low gestational age, low birth weight, prolonged oxygen support, prolonged mechanical ventilation, APGAR at 1 minute less than 6, presence of respiratory distress syndrome, apnea, surfactant use, PDA, intraventricular hemorrhage, sepsis, anemia, neutropenia, thrombocytopenia, history of blood transfusion, ileus of prematurity, and a new risk factor we saw was history of undergoing any early neonatal surgeries was significant in babies with ROP. Coming to the babies, the subclassification of ROP, we saw babies developing type 1 ROP had a lower gestational age, lower birth weight, prolonged duration of oxygen support, particularly on ventilator, and these were significant. Comparing the progression based on the gestational age, we saw babies with type 1 ROP, which can be seen with the blue color. They peaked at around 26 to 28 weeks gestational age, followed by the type 2, which was seen around 28 to 30 weeks, followed by mild ROP, which were little heavier babies between 32 weeks. And comparing the progression associated with the birth weight, we saw both type 1, type 2 were seen around 900 to 1100 grams, whereas mild ROP were a little heavier beyond 1900 grams. Comparing the risk factors between the subgroups, we saw history of RDS, apnea prematurity, surfactant use, PDA, sepsis, anemia, thrombocytopenia, blood transfusion, oxygen support, and again, history of going early neonatal surgeries were higher in babies with type 1 ROP, which was significant. On multivariate analysis, we found only history of blood transfusion was significantly associated with type 1 ROP. Comparing the PC at which ROP was first detected in any of the babies was 35 weeks, started regressing by 39, and started completely regressed by 49 weeks. So this is a graph that again shows the mean PC at which each of the subgroups were detected. That was around 34 weeks for type 1 and type 2 ROP. Mild ROP was detected a little later at around 39 weeks, started regressing by 39 weeks, both type 1, type 2, and mild ROP a little later, 41 weeks, whereas type 1 ROP took a little longer time, beyond 50 weeks, to regress completely, whereas type 2 and mild ROP regressed earlier, between 46 to 48 weeks. Coming to the discussion, we saw that amongst all the babies who requiring treatment, that is type 1 ROP, was seen around 37.3 babies. And this is similar to the study done by Imran et al. Because they also had a similar inclusion criteria of gestational age less than 34 weeks. Whereas Cryo ROP and Alex ROP had a little lesser cutoff incidence because their gestational age was around 31 weeks. We also observed that more of these babies with multiple systemic comorbidities were progressing to type 1 ROP. And because of these factors, they were indirectly or directly causing an imbalance in the vascular and between the vascular and avascular retina, which caused an upregulation of VEGF levels, thereby possibly causing a progression. We also observed the type frame progression and regression of ROP between the babies and saw both type 1 and type 2.
Your time is up quite quickly.
So type 1, type 2 were detected early and type 1 took a longer course to regress. So I'll just go to the last slide then.
No, go ahead.
So the limit. Just to conclude, sir, I just want to say that the study showed that the period between 34 to 39 weeks is crucial for these preterm babies with multiple systemic comorbidities, as the progression is typically seen in this period. And also one more point we noted, that babies with type 1 ROP should be followed up till complete regression even beyond 50 weeks, because few babies have been seen even after treatment to have smoldering ROP. Thank you.
Yeah, what take-home message, because what is new in your paper you want to convey compared to what is already available literature?
Yes, sir. So new thing we saw that the babies specifically with early neonatal surgeries, they were going these surgeries apart from such as herniatomy, resection, anastomosis. They were undergoing these at around 34 to 36 weeks. So possibly because of this, there was a prolonged ventilation, and they were given additional blood transfusions that possibly added on to the progression for type 1 ROP, because that period is crucial between 34 to 36 weeks.
Where did they get the criteria of 2500 grams and less for screening?
Yes, sir.
The screening criteria was 2500 grams or less.
So the
Actually, the Rashtriya Vikas, they says 2000 grams and less.
Yes, sir. Before that,
why did you increase the weight?
So because we saw a few babies, and we routinely doing it in our hospital, few babies between 200 to 2500 grams were also developing ROP. So based on the previous IAP guidelines, sir.
Okay.
Thank you, sir.
And next speaker is Dr. Punita. She's here. She's going to present on us.
Could you see the time? Honorable chairpersons and my dear friends, I'm going to speak on association of neovascularization with optical coherence tomography angiography parameters. One of the main cause of visual loss in proliferative diabetic retinopathy is formation of neovessels, which leads to tractional retinal detachment and vitreous hemorrhage. Previously, they were diagnosed with use of fluorescein angiography, but which has shortcomings that it does not see all the segments of retina and choroid. Optical coherence tomography angiography does this and shows various features like macular ischemia, capillary dropout, and differentiate neovessels from IRMA. Chronic hyperglycemia leads to ischemia by microvascular changes, and this ischemia causes neovessels, which in turn again leads to ischemia because of abnormal flow. So, change of fast parameters and vessel density parameters is the cause and consequence of proliferative diabetic retinopathy. The aim of the study was to find association of neovascularization with OCTA parameters in subjects of PDR to find possible biomarkers. The study was approved by Institutional Ethical Committee and informed consent was obtained from the participants. It was done at Department of Ophthalmology, Guru Nanak Eye Center in a prospective observational study in 41 treatment-naive PDR patients in the age range of 40 to 70 years, including 28 males and 13 females having mild, moderate or severe PDR as per ETDRS classification. Subjects having other coexisting diseases having previous treatment history or high refractive error or media opacity were excluded. The history and examination was done for various visual symptoms including color vision and contrast sensitivity, and HD-OCT was done for these features, and only subjects having vision of 6/60 were included. Neovascular complexes were diagnosed with at least 2 types of multimodal imaging. OCTA was done with NIDEC model in 3 into 3 millimeter scan to study phase and vascular density. The primary outcome parameter was OCTA parameters, and Mann-Whitney test and Crooks-Wally test were used to find association. This shows the demographic and various presentation of the patients. Mean distant best corrected visual acuity was 6/36, IOP was 17, and contrast sensitivity was 0.9. The neovascularization disc was present in 19, elsewhere in 64, IRMA in 35, vitreous hemorrhage in 6, and the right side table shows all the OCT features. The OCT qualitatively showed enlarged distorted phase and macular ischemia from disintegrity of vascular arcades. This is how the various layers are scanned in OCTA in NIDEC model. The association of neovascularization was found significant with phase area and superficial capillary plexus, as in the right side extreme normal value is 0.4 in phase area, and just left column 0.5 is there in the patients having NVD. And 23 is the normal value of vascular density in superficial capillary plexus, whereas it is just 7, like 1/4 in patient and having neovascularization disc. Similarly, neovascularization elsewhere had significant association with phase area, outer retina vascular density, and choriocapillary vascular density. The vitreous hemorrhage had significant association with phase parameter and superficial capillary plexus, and the presence of IRMA had significant association with vascular density in DCP, OR, choriocapillaries, and choroid. Previous authors have studied OCTA features, but they have only studied the incidence of neovascularization disc elsewhere in IRMA in their studies, but they have not found the correlation of other parameters with these neovascular complexes. They have only found that phase area and perimeter increase and circularity reduces with severity of diabetic retinopathy, and they have got a significant association with visual acuity. Few authors have studied only 2 layers and then found that DCP gets affected earlier and SCP escapes because of steal phenomenon. Liu et al. Also found that choriocapillaries vascular density is affected in subjects having diabetes. So Moyer told that vascular density and phase parameters are possible biomarkers, but they are not studied because there are shortcomings in the software incorporated in various equipment. We studied all the 6 layers of retinochoroid with all the 3 types of neovascular complexes as well as vitreous hemorrhage, and found that one or the other layer was affected whenever these occurred. So we conclude that phase parameters and vessel density in different retinochoroidal layers, they are biomarkers, because if their magnitude is affected, then we can say either the neovascular complex is existing or it is going to shortly occur, and there is less control of diabetes, so patient should have aggressive treatment and better control of diet. The only shortcoming of our study was we used 3 into 3 millimeter scan, which is short, and we had to have more of movement of these scans to take the readings of neovascularization elsewhere, which was near the posterior pole. But this has got better resolution, as the literature says, than the wider scans. Thank you.
Thank you, ma'am.
In your study, though the p-value was significant, the standard deviation was too high. Have you calculated confidence interval?
No, that I'm not going to.
Yes. So it becomes meaningless because you can't derive a biomarker that if you have a value like this, you will have this.
No, but
because the standard deviation, go to that slide.
Yeah, if the standard deviation had, that
Go
is
to that
non-parametric data.
Go.
That's a non-parametric data that was considered.
Wait for a minute, I'll just show you. Okay, take care of that next time. So when you want to draw a conclusion, p-value alone is not significant or not relevant because you have to have a standard deviation within the range. There was tremendous overlap between the standard deviation, and if you take confidence interval, it will go out. And so p-value has no meaning if your confidence interval is way higher.
But when absolute values are very low, like 1/4 of the normal values.
Okay, let's stop here. We can discuss later on.
Thank you.
Thank you, madam. Next speaker is Dr. Sirin M. D'Souza. Dr. Shirin is here.
Same paper.
Dr. Santosh Mahapatra is going to speak on 52 weeks safety and efficacy of optogenic therapy for vision restoration in RP with ABCA4 mutation.
This study, I am the principal investigator. I have no financial interest. All the papers related to ethical clearance and genetic study have already been submitted to the scientific committee as desired in the last year. So why optogenetic gene therapy? It's because the available therapies for RP, like use of electrodes, are invasive and has limited resolution. The classical mutation-specific gene therapy requires presence of photoreceptors, and they are not available in advanced RP. But in optogenetic therapy, you can introduce a special gene that enables these neurons available to be stimulated to the ambient light, and it is effective for varied disorders. And the monochromatic abscine, which was earlier used, required intense light, produced suboptimal stimulation, and required goggles to stimulate the retina. In contrast to the multi-characteristic abscine, which we have used, is activated in ambient light and generates significant photocurrent without use of goggles. And this is delivered by a very simple approach of intravitreal injection into the eye, just like any other intravitreal injection. And the target cells are bipolar cells. And here we had 11 patients which are included for the study, but out of them, only 4 had ABCA4 mutation positive patients. And the key enrollment criteria was either light perception or hand movement, and in the other eye, there was no better vision than counting finger. And all the subjects in this group are in the high dose group. So this is the gene panel for all the subjects which are included in the study, 11 subjects. Out of them, subject number 5, 8, 9 and 10 had ABCA4 mutation. And all the subjects underwent neutralizing antibody testing at week 4, which showed there is no neutralizing antibody found to the MCO. The safety profile in all these 4 patients we had no serious adverse effect apart from 2 subjects had 2+ AC and vitreous cells, and 2 out of them had mild increase in intraocular pressure, 2 had mild increase in inflammation, and all subjects were well controlled with topical medication, and no subject required any additional oral steroid or glaucoma surgery. There was clinically significant improvement in visual function, which was correlated with visual fields in 2 subjects, and the fundus autofluorescence showed a longitudinal increase in response in all the subjects, which are showed through fundus autofluorescence till 16 weeks and which are maintained till 52 weeks. Here is a patient which video. Yes. Yeah. Here is a patient who was tested on Y mobility test and instructed to locate the light. You can see he's very grossly moving and not able to locate the light pre-injection, and at 16-week injection, the same test, same patient, and you can see the way he is moving and trying to locate the light, and he is exactly locating light in his left as well as right hand. So to summarize, there is no serious adverse effect on study safety profile with only mild increase in intraocular pressure and ocular inflammation, which are well controlled with topical medications. And there is no increase in neutralizing antibodies against MCO in serum, suggesting there is no systemic immune response. And the dose-dependent efficacy at 52 weeks after single intravitreal injection was proved by improvement in fiber visual acuity, less error and time in visually guided response in Y mobility test, high visual field index, and improvement in discrimination of shape and optical flow direction, as well as increased NEI visual question function error scores. And with this good safety and efficacy results, a randomized double-masked control study is being conducted at US at 6 centers at this point of time. I'd like to thank my co-investigators and authors for this wonderful study. Thank you.
So any question?
The material you inject actually is supposed to stimulate the bipolar cells?
Yes, because all the subjects included are advanced RP subjects with very little photoreceptors present, and presence of bipolar cells and ganglion cell layers were demonstrated in pre-injection OCT.
But there are only ganglion cells which are supposed to be light sensitive, not bipolar cells. How do you confirm that it's stimulating bipolar cells or ganglion? Is there any way?
Yeah, we are taking a M-cherry coat for autofluorescence testing before and after the injection also,
Okay.
which is shown in the photographs.
Okay, thank you. Good. Hope we'll get more results in future.
Yeah,
This
this
was
is
done
the
in
pilot study which is conducted in our institute, and they are planning to come back to India with multi-center study for the phase 3. Now it is going on in US at 6 centers.
Very good. Yes.
No, it is coming from US with respective clearances from the government of India. Yes, we have taken ethical committee clearance, and that point of time when the study was conducted in 2019, that gene therapy specifications as per the government of India guidelines. And all the papers we have submitted to the scientific committee also. Last time I presented the 16-week data, preliminary primary endpoint report, and also participated in Colonel Rangachari. And this is the 52-week data which I am presenting now.
Next paper is by Dr. Prabhu Bhaskaran. He's going to present comparison between ILM peeling versus inverted flap for large macular holes.
Good afternoon, one and all. This is a randomized control trial comparing the outcomes between conventional ILM peeling versus perfluorocarbon liquid assisted inverted flap surgery in large macular hole. So it's a known fact that the closure rate in conventional ILM peeling surgery in large macular hole is less, 50 to 80% compared to smaller medium-sized holes. That's why inverted flap surgery was suggested by Michael Swa in the year 2010 to increase the success rate. But there are certain things that we need to look at. The short-term results of this inverted flap is well studied, but in literature, the long-term effects is largely lacking. Also, as it was categorically mentioned by Michael Zua in its original paper, the flap dislodgement rate was 14%, which was more, and that's a kind of rate limiting step in determining the success of this procedure. That's how Park et al. Later in subsequent years, he suggested the role of PFO to achieve better success rate, but there is no RCT till date to prove if PFO assisted surgery is really beneficial or not. Also, there is additional ambiguity in in this segment. We don't know exactly the difference between ELM and EZ recovery rate between these techniques, and also the time taken for this flap to disintegrate with the surrounding structures. With this background, we thought of conducting a RCT between these two techniques. So our purpose was to analyze the outcomes following conventional ILM peeling versus perfluorocarbon liquid assisted in inverted flap technique in large macula hole. So this is a prospective double-blinded RCT conducted, approved by our institutional ethics committee, conducted at our institute and registered with CTRI India. So we conducted the study between Jan 2018 and December 2020. So we included patients who had large idiopathic macular hole with aperture size of the minimal hole diameter more than 500, and we excluded patients if the hole size was less than 500, also secondary to other etiologists or coexisting ocular pathologies or monocular patients and pediatric subjects, etc. And apart from the routine baseline evaluation, all patients underwent the OCT procedure in Heidelberg. We specifically looked at the minimum diameter, maximum diameter, and the height of the macular hole. So we used Microsoft Excel automated sampling to randomize these patients. We gave 2 codes, surgical code. One patient would undergo conventional surgery, and 2 inverted flap surgery will be done. These codes were opened just before commencing the surgery and opened up to the surgeons. So as far as the surgical technique are concerned, we selected 3 vitreoretinal fellowship trained senior surgeons with experience more than 5 years. Technique number 1, conventional surgery. It's a standard 25 gauge surgery. We used Brilliant Blue G dyed 0.2 ml, manufactured by Aurolab India. The ILM, the initial flap was raised either using finesse loop or pinch and peel technique and extended around 2 disc diameters around the macular hole, and either a short acting or a long acting gas was used according to surgeon's discretion at the end of surgery. And this is inverted flap technique. Here the steps are the same except for the fact that a small flap of ILM was retained around the edge of the hole, and the size of which was trimmed using cutter at the rate of 1000. We preferred 1000 cut rate per minute, and with a suction of 50 millimeters of mercury. And as you can see here, I'm trimming the flap, and we used a PFO bubble, small bubble, and stabilize the flap inside that, and we used a fluid to aspirate the saline completely, and before we approach the PFO bubble, and then we approach the PFO bubble so that there is no saline to displace the flap, and FAE is done meticulously at the end of the surgery. So the sample size was kept at 99 eyes with a to prove a superiority limit of 10% between the 2 techniques, and the level of significance was set at 5%. So outcome measures, we looked at these are the outcome measures. Primary outcome measure was the difference between the closure rate between the techniques, and secondary outcome we looked at mean BCVA between the techniques, and also we looked at recovery rate of ELM external limiting membrane and EZ ellipsoid zone layers between the groups, and also we looked at closure rate between the techniques using different gas tamponates. And we also looked at rate at which the time taken for the ILM flap to disintegrate completely in the inverted flap group. And we also looked at the difference between subfoveal thickness between the groups in closed macular holes. The primary study endpoint was kept at 3 months, and the secondary, we had 2 secondary endpoints at 6 and 12 months. So we followed up these patients till 1 year. So post-operative, patients were examined at 1, 3, 6, 9, and 12 months. Apart from the routine examination, OCT was done primarily to look at the hole closure, of course, and the type of closure, and the restoration of ELM, EZ layers, and the visibility of ILM flap, whether these blinded graders could see the ILM flap in inverted flap group or not, how long they could see. All of that we noted, and both intraoperative and postoperative complications were documented. So these are the definitions that we used in our study. If there was complete flattening of macular hole over the underlying RP, and if there was complete absorption of subretinal cuff, it's there is anatomical success or closure. And in addition to that, okay. Sorry, go to the results. Can I get to? Yeah, sure, sure. So, so in our study, basically, we didn't find any statistical significant difference between the two techniques in terms of closure rate or visual outcome or the recovery rate of foveal structures. Interestingly we found that the subfoveal thickness was more in inflap group, which probably suggests that though the inverted flap group showed better closure rate, though it was not statistically significant, probably the increased subfoveal thickness, we are probably hindering the natural regeneration of subfoveal structures by creating putting excess flap into it. Probably in future studies we need to look at measures to gauge the ILM flap. Thereby we could achieve better results with this. Thank you. Yes.
Strange that actually we see that actually the inverse flap has better results, but you have thrown up that they are almost equal. There are only few papers which tell that. And in that actually you had 3 surgeons. Did you analyze surgeon-wise data of closure rate?
Not really, sir.
Okay, thank you.
Thank
Just a suggestion, there are a lot of confounding factors. So control that.
So next paper is on color visco-assisted ILM flap placement, technique for large macular hole, Dr. Atul Dhawan.
What happened to this? The one cancelled. Not permitted.
Good morning, everyone. My topic is color visco-assisted ILM flap placement, that is CAP, in large macular holes. So for the large macular holes, so many options are there, like retinal autograft, amniotic membrane graft, retinal expansion by the subretinal injection of the senine, retinal massage. But the most common thing which we are using from the last 10-12 years is inverted ILM flap, which was shown by Dr. Zofia Michelwaska. She has given the first paper in 2010, that was conventional ILM flap, then in 2015 the temporal ILM flap. But always there was anxiety because 3 questions were there in front of us. How to make a good flap, how much big flap, and how to keep the flap over the hole till the end of the fluid air exchange. So because I am from Chennai, I have learned this how to make a good flap technique from Sarvana Doshe shop. The answer of the second question is how much big flap. So if we'll go by physics, to separate the 2 glass plates which are separated by one thin film of water, we have to apply some force. That force is directly proportional to the area of contact. So if the area of contact is large, the chances of flap removal during the surgery is very less, and in the post-op period also. Because of this, I have taken large flap. The third one, to keep the flap over the hole till the end of surgery, we need a temporary tamponade. For that, I have taken the viscoelastic, which I have colored with the help of brilliant blue. This is a small technique, CAP. How to color the blue viscoelastic? I have used the 2% HPMC. I have colored it with the help of 1 drop of brilliant blue. You can see, just shake it and color it. Now this is a large macular hole, and I have used 180 degree of the flap, this is 550 micron minimal hole diameter, and the pre-op vision was 660. Patient was glaucomatous. The vision was deteriorating. That's why I have gone for the surgery in this case. I have used finish loop to make a flap. The best quality of the finish loop is you can control the tensile strength of the finish loop by decreasing or increasing the size of the finish loop inside the eye. So first is 180 degree finish loop. Now I am making the flap with the help of the ILM peeling forceps. You can see there is an angle between the retina and the forceps, and by this I can see directly the ILM, and there will be no injury of the retinal nerve fiber layer. After this, I'll put the flap over the macular hole, and in this bare area, I'll put the temporary color viscoelastic, tilt the eye towards the disc, and take out the viscoelastic at the end of the surgery. This was a U-shaped macular hole. So the result of my surgery was, we have taken 30 patients, 67% female, 33% male in my study. The mean age of patient was 67 years in the female and 73 years in the male. 15 case of the left eye, 15 was the right eye. Best corrected visual acuity, I have taken pre-op, 1, 3 and 6 month post-op. You can see 30 patient pre-op and 29 patient in the post-op, because in one patient I have to do one re-surgery before first month. So I have excluded from the study. The vision was increasing gradually. Now the foveal morphology, re-establishment of the external limiting membrane at the day 7, 1 month, 3 month and 6 month. You can see from no medium to, it has gone to partial and complete at the end of the 6 month of the surgery. The same thing we have seen for the ellipsoid zone, 7 days, 1 month, 3 month and 6 month. From no and partial, it has gone to partial and the complete. Now we have compared this with the visual outcome. In the case of ELM, a significant association was noted when comparing the ELM formation with the visual outcome. You can see here, the visual outcome was much better when the complete ELM was there, and it was less when the ELM was less. The same was there in the ellipsoid zone. Now we have compared the group 1, group 2, group 3, which is fully formed, partially formed and no formed ELM and EZ. And we have found these results. Fully formed, the hole was small, and partially formed, it was large. We have found visual outcome. The 26 cases were the U-shaped closure, and the 6 cases were the V-shaped closure. The visual outcome was much better in the U-shaped closure than the V-shaped closure. It is shown here, 23 cases U-shaped, 6 cases V-shaped. Minimal hole diameter, if the minimal hole diameter was less, then U-shaped closure was there. If it was more, then the V-shaped closure was there. Final visual acuity less than, if the CMT was less than 200, the final visual acuity was less, and if it is more, it was better visual acuity. The conclusion is, color visco-assisted tamponade for temporary purpose is much safer and better than the normal, and U-shaped closure favors the better visual outcome. Thank you.
Nice presentation, thank you. So the next paper is by Dr. Satya. Not there? Okay. So we go ahead with the next paper. Yeah. So next paper is by Dr. Sabia. She's going to present on cluster outbreak of Pseudomonas acute endophthalmitis following phacoemulsification.
A very good noon to everyone. The title of my presentation is Cluster Outbreak of Pseudomonas surgery acute endophthalmitis following phacoemulsification. So endophthalmitis is the most dreaded complication for any ophthalmologist, and the most common organisms implicated are gram-positive, coagulase negative staphylococci followed by gram-negative. So among gram-negative bacteria, Pseudomonas aeruginosa is the most commonly isolated species, including the cluster outbreaks. And Pseudomonas surgery has been reported to cause isolated cases of post-operative endoph. However, a cluster outbreak has not been reported so far. So the aim of my study was to describe the demographic profile, clinical course, microbiological profile of 14 patients who presented with acute Pseudomonas surgery endophthalmitis following phacoemulsification. So 14 consecutive patients operated on the same day were included, and the emergency retina services of PGI were alerted, and the primary surgeon was advised to call back and examine all the patients operated on the same day. So an immediate disaster management response team was made, and the team was divided into 3 parts. One team took care of patients who required tap and inject. Second team prepped the operation theatre, and the third team coordinated between these two. So the patients were divided into severe and mild presentation. The severe presentation patients underwent immediate pars plana vitrectomy with antibiotics, and the mild presentation patients underwent vitreous tap and injection. So the gram and QH wet mount was performed, and the cultures were obtained for bacterial as well as fungal cultures. And after overnight incubation, samples showing pure growth were identified using MALDI-TOF mass spectroscopy, and antibiotic susceptibility was done using VITEC, and the results were available within 6 to 8 hours. And the environmental surveillance was also done at the operation theatre of the primary operating surgeon, and surveillance samples were obtained. So 14 out of 22 patients were operated on the same day. They developed acute post-op endophthalmitis. 8 were males, 6 were females. Mean age was 62. And the best corrected visual acuity ranged from light perception to 20/80. So the presenting signs were corneal folds and circumciliary congestion in all, hypopyon in 8, fibrin in 7, and none had corneal involvement. So 10 had mild presentation and 4 had severe. This is the table highlighting the presenting features and the primary, secondary intervention, anatomical functional outcomes. 4 patients had severe presentation and they underwent upfront vitrectomy with injection of intraocular antibiotics, and 10 had mild presentation. 1 patient who had severe presentation had intraoperative central retinal artery occlusion, and she had an unfavorable outcome. So majority of the patients had a favorable outcome, and the visual acuity improved even up to 20/20. So this is one example of a patient with mild presentation who underwent vitreous tap and injection of antibiotics. And this is an example of patient with severe presentation. She had hypopyon, fibrin, corneal folds, dense exudates, and post-vitrectomy and injection of antibiotics, the media improved and the vision improved to 20/20. So the microbiological analysis was obtained, and we can see that the gram stain slide showing a gram-negative bacillus and the culture showing Pseudomonas sedzeri. Also PCR was done with the primers available for Pseudomonas sedzeri, and all patients were found to have this organism. The antibiotic susceptibility pattern was similar, and luckily the organism was sensitive to the all available antibiotics, and the surveillance samples from the air conditioning system sent to the local laboratory by the primary surgeon grew the same organism. However, it was not available to us for further analysis, and the surveillance samples analyzed at our laboratory did not grow any significant organism. So all eyes except 1 could be salvaged, and 8 patients improved to 20/40 or better. So to conclude, the management of cluster endophthalmitis is a multidisciplinary teamwork, and prompt identification of the organism and the antibiotic sensitivity aids in the treatment. So our study provides insights into the clinical profile of a endophthalmitis secondary to Pseudomonas sedzeri. It's a lesser known cause of intraocular infections, and the majority eyes had luckily mild presentation and could be salvaged.
Thank you. Any questions, sir? Should we go?
Thanks. Thank you.
The next speaker is Dr. Shweta. She's going to talk on idiopathic epiretinal membrane and its novel association with hyperreflective foci.
Good afternoon, everyone. I'm Dr. Shweta. The title of my presentation is Idiopathic Epiretinal Membrane and its novel association with hyperreflective foci. We do not have any financial interest. So let's talk about the inception. It all started when a 65-year-old male patient with an NS2 grade cataract presented to us with an idiopathic epiretinal membrane. So this was his baseline OCT preoperatively, and he had a central macular thickness of 335 microns with a grade 2 ERM. He underwent a combined uneventful phaco-IOL with vitrectomy surgery with ERM peeling. As we can see, the anatomical outcome looks good. The ERM is well peeled. The foveal contour is normalizing. So it is. But the central macular thickness, to our surprise, increased from 335 microns to 367 microns, and the best corrected visual acuity dropped by 1 line. So it led to a lot of commotion. We started wondering what could be the cause for this increase.
Excuse me, did you present this in the last session also?
So this was state best paper session, sir. That was
No. What I was asking is, did you present it the same or it is different? Same. So
It's a state.
yeah. So we will not mark it in this session because it was marked in the last session, but you can present. Okay. Thank you.
okay. So this led to a lot of commotion because we started wondering what could be the cause for the drop in vision. And when we went back to the OCT, we saw a few fine hyperreflective foci. And we went back, this is an unusual finding because this is not commonly described in ERM. We went back to many other patients' OCTs and we found similar findings in many of these patients. So we decided to study the novel association of hyperreflective foci with idiopathic epiretinal membrane. So we included patients who underwent surgery for idiopathic ERM between Jan 2018 and Jan 2020 with or without adjuvant steroid as per the surgeon's discretion and patients who had follow-up of at least 1 month. So all OCTs were done on TopCon DRI OCT Triton Plus machine. 12 into 12 mm radial scan centered on the macula with a minimum sound to noise ratio of more than 35 was included, and the images were graded by 2 different assessors independently and the average was taken. So we used the Goveto classification here to grade the ERM. Stage 1 is the ERM where there is negligible disruption of retinal layers. Stage 2, there is stretching of outer retinal layers. Stage 3, if the ectopic inner foveal layers have crossed the central fovea. Stage 4, where there is disorganized anatomy of macula altogether. Statistical analysis was done. A p-value of less than 0.05 was considered as statistically significant. We had 13 male patients and 11 female patients. As per the staging concerned, 5 eyes fell into stage 2, 14 into stage 3 and 5 in stage 4. So the hyperreflective foci, as we can see, increased as we went up the stage and the central macular thickness also increased as we went up the stage. As we can see in the table here, the mean hyperreflective foci is 4.2 in stage 2, which increased to about 59.2 in stage 4. And the central macular thickness also was significantly high as we went up the stage. This was statistically significant. Now I would like to present 2 cases here. The first case where it's a stage 2 ERM with a preoperative central macular thickness of 304. After 1 month of uneventful combined phaco-IOL with vitrectomy surgery, came out with a central macular thickness having increased to 332 microns, but the best corrected visual acuity has improved. On the other hand, we have another case of a much worse condition, stage 4 ERM, with a central macular thickness of 554 at baseline, which improved to 448 at post 1 month follow-up after a combined phaco-IOL vitrectomy surgery. But the key here is the patient also received an intravitreal dexamethasone implant. So we compared these 2 groups, the group with steroid and without adjuvant steroid, and we saw that the patients who received steroids along with the surgery did better as compared to the other group in terms of reduction in central macular thickness and also in terms of the hyperreflective foci decreasing. The graph here shows the hyperreflective foci steeply decreased between 1 month to 3 months in the group which received steroids. So what are we trying to interpret here? There's one study which describes hyperreflective foci in idiopathic ERM, but the clinical relevance is not mentioned. There are few studies which advocate the use of steroids in ERM surgery, but we do not have a strong rationale for that. And there are few studies which speak about the role of inflammation in idiopathic ERM. We feel that our study is the one that connects the dots and gives us a rationale as to why steroids work better, because the hyperreflective foci are there and they signify ongoing inflammation. So we would like to imply that when there's subclinical inflammation in terms of hyperreflective foci or when there's macular thickening or both, then we would advocate using intravitreal steroids, especially if the ERM is of stage 3 or 4. That way, we'll have a better improvement in the central macular thickness, better visual acuity improvement, and we'll have a happy patient at the end of the day. Thank you so much.
Thank you very much. I think the last talk today will be Dr. Aditya.
Thank you.
Everyone, thank Thank you so much for the opportunity to present. I'll be presenting our study on retinal microvascular changes in non-diabetic chronic kidney disease on hemodialysis. It's an OCTA-based study. So what is CKD? CKD is defined as kidney damage with glomerular filtration rate less than 60 milliliters per minute per 1.73 meters square for 3 months or more, irrespective of the cause. The leading cause of CKD in India is diabetic nephropathy. The retinal changes in CKD include decreased retinal vessel caliber, focal arteriolar narrowing, AV nicking, and opacification of the arteriolar wall. These changes are expected in hypertensive retinopathy, and most patients of CKD have hypertensive retinopathy. So stage 5 CKD, as per the KIDGO classification, is defined as GFR less than 15 milliliters per minute. In our study, the aim is to analyze the OCTA changes in the retinal microvasculature in non-diabetic stage 5 CKD patients undergoing regular hemodialysis versus age-matched healthy controls. So via OCTA, we studied the superficial vascular plexus, the deep vascular plexus, the chorioacapillary layer, and the FAZ area. It is a prospective single-center cross-sectional observational study conducted between December 2020 and June 2021. The sample size of 60 eyes, that is 33 patients in the CKD group, and 60 eyes, 30 patients in the control group was determined. The inclusion criteria in the CKD group included age greater than or equal to 21 years, and the patient had to be non-diabetic, stage 5 CKD, diagnosed by a nephrologist, and had to undergo regular hemodialysis of at least 12 hours weekly in 3 divided sessions. And the machine used was the Fresenius 4008S machine. And the exclusion criteria was diabetic CKD patients, any patients with presence of significant ocular media opacity such as cataract, and any pre-existing macular pathology or inability to obtain an adequate quality OCTA and OCT image, and pregnant patients. Coming to data collection, all participants of the study underwent a complete ocular exam, including vision, refraction, fundus exam, fundus photography, and swept source OCT and OCTA imaging on the DRI Triton Plus machine. And OCTA scans of 4.5 into 4.5 milliliters centered on the fovea were captured. In this image here, we can see the red areas are the vessel areas, and the blue areas are the non-vessel areas. And in the center, we can see the FAZ. So the vessel and non-vessel areas were quantified using local fractal analysis technique, and MedCalc statistical software was used for doing the statistics, and all vascular parameters such as the SVP, DVP, choriocapillaris, vessel density, and the FAZ area were expressed as median and 95% confidence intervals, and Kruskal-Wallis test was used to compare the vascular parameters between the CKD and the control group. A p-value of less than 0.05 was statistically significant. So coming to the results and observation, we see that there were more males than females in both of the study groups, and the mean age in the CKD group was 44 years, whereas in the control group it was 49.5 years. And the etiology of CKD was diverse in our study population, the most common etiology being chronic glomerulonephritis, that is 28 out of the 33 patients. Within CGN, the commonest cause was hypertensive nephrosclerosis, and the second common cause was idiopathic etiology. Then all 33 patients in the CKD group had hypertension as a comorbidity. And coming to the vision, so 97% of the patients in the CKD group had a vision of 6/6, and only 2 patients had 6/9 vision. So all of them were visually asymptomatic and had good visual acuity, whereas control groups, all patients had 6/6 BCVA. We also analyzed the 45-degree central color fundus photographs of all 60 eyes of the CKD group and graded as per the Keith-Wagner-Barker classification, and found that 43% of the eyes had no evidence of hypertensive retinopathy clinically, whereas 57% had some degree of hypertensive retinopathy. Here we have an image of a patient with grade 3 hypertensive retinopathy with vein occlusion. So out of the 60 eyes that we took in the CKD group, the OCTA images of 23 eyes were not clear enough owing to various OCTA artifacts, and these scans were ineffective for fractal analysis and quantification of vascular parameters. Hence we excluded those, and only 37 eyes the OCTA images were taken and compared with 40 eyes in the control group. Coming to the outcomes, in the superficial vascular plexus, we can see here in the CKD group and the control group, there was a significant difference in the vessel density in the CKD versus the control group. The CKD group, we can see there's altered FAZ, there's reduced vessel density and capillary rarefaction present. The red areas indicate areas of blood flow, and the blue indicates avascular regions. The p-value was significant, so less than 0.01. Similar changes were there in the deep vascular plexus. We can see there's reduced vessel density, altered FAZ, and capillary rarefaction. it was this in the DVP also there was significant difference. Coming to the FAZ area, it was not significantly different between the CKD and control groups, neither in the superficial layer nor in the deep layer. And then we moved on to the choriocapillaris layer. So we took octa images of the choriocapillary layer from the Brooks membrane to 20 micrometers into the choroid, and there was attenuation of vessels in the choriocapillaris in all of the patients. However, this could not be used for quantification of vascular parameters, hence we decided to take a segment from the deeper choroid from 60 to 80 micrometers, and that showed a significant difference of P less than 0.01. So our study found that the SVP and DVP vessel densities were significantly lesser. There was choriocapillary attenuation in the CKD group. The choroidal vessel densities were significantly lesser. There was altered FAZ. And in our study, we excluded the diabetic etiology of microvascular alterations so as not to have any confounding factors. And so as to more closely explore the pathology that's present in CKD and hypertensive retinopathy. Concluding,
Yeah, you can just finish it.
Okay, so what we found in the eye is that these microvascular alterations are also present in other areas such as the brain, heart and kidneys, and this is the main principal pathogenic factor in development of severe organ dysfunction in CKDs, and octa can be used as a tool to prognosticate and document these changes before visual symptoms develop. Thank you.
Good, thank you, nice presentation. Well, thank you.
It's okay.
Discuss much on this.
It's okay. Understand.
Excuse me. So how does the CKD cause these changes or the hypertension?
Yes, so I think it's the hypertension as well as the uremic status and the volume overload because of end-stage renal failure.
So the study would have been better if you had taken hypertensive patients without CKD and CKD patients with hypertension.
Yes, sir. That would
have been
study.
better study, I think.
Yes.
Anyway, thank you very much.
Thank you so much.